Hello, and thank you for asking me to speak today. I'm Tom Thayer, and I'm sorry I can't be there in person, but that's the vagaries of the West Coast Main Line. I've been asked to speak on dentistry in the 21st century. So before I start that, I'm just going to remind you of the dental landscape. You'll be familiar with the general dentist in the high street, and some of you will be familiar with specialist dentists who provide specialist care such as orthodontics and perhaps endodontics and oral surgery. But there are many other groups that support the primary care practitioners. Hospital dentists like myself, I work in a dental hospital, and there are many of my colleagues who work in district general hospitals across the country. We also have a very important thread with the community dental services who provide support to those vulnerable patients particularly, and a large group of university dentists who provide training for over 800 graduates every year. And finally, we mustn't forget our colleagues who are in the defence dental services, who interface with the NHS as well, and of course contribute to the NHS during their training. So what's the problem with dentistry? In the 21st century, dentistry's got itself into quite a significant amount of trouble. And you'll be aware that access to dentistry is very difficult now. Unless you can pay, of course. There are too few and too poorly funded practices. A payment system that lacks disease sensitivity. And what we have to remember is that dental practices are small businesses. They need to make a profit to survive. And if they don't make a profit, they don't survive. And that means that nobody has a service at all. The great thing is that dental practices are incredibly cost efficient. They always have been since the very first day of the NHS in 1947, and they have managed a vast amount of disease in the second half of the 20th century. Unfortunately, in the 21st century, they're in a situation that has limited their ability to cope with this any longer. Now, you won't be surprised to know that this is down to funding. If we look at this graph, funding on the left-hand side is looking at the increase in NHS expenditure on the parts of the NHS, of NHS England and NHS providers. And they've had about a 40% increase in overall funding in the last 5 years. If you look at dentistry on the right-hand side, it's had 3.5% in 5 years. And that is only really occurred as a consequence of COVID payments. Pharmacy looks slightly better, but again, that is largely due to COVID payments. So funding to dentistry has basically remained flat for the last 5, in fact nearly 10 years, and has stayed at round about 3 billion, despite the fact that a year or so ago we had an inflation rate of 11%. So this is very challenging for dental practices. Their costs have increased dramatically, but their income has stayed flat for years. So they've had a very substantial real terms cut in income. This is compounded by very destabilising short-term contracting arrangements. And dental practices are increasingly forced to make changes to survive, or as I said before, they will close. And the short-term contracting arrangements are a particular problem for developing new practices, because you've got to consider that to develop a new practice is probably going to cost somewhere around £2 to £2.5 million when you take into account the cost of the building, the equipment, the staff and everything else. Nobody's going to put that money out if they're not guaranteed a contract that will help them pay that back. So NHS practices are being forced out of NHS provision. And this reduced availability means that more dentists are doing private work, but it means they're seeing less patients. Even if you can pay, it's sometimes difficult to get into a private practice because there simply isn't the volume of practitioners out there to cope with that amount of work. So what's the problem with dentistry? It's being strangled out of existence. There is also a significant knock-on effect. Changes in family practices change workloads elsewhere. They change workloads in private practices. They change workloads in community services. They change workloads in hospital services. And they particularly change impact upon hospital services. The elephant in the room with all of this is COVID, of course, because family practice has never really caught up with the delays produced by COVID. But we've also seen as a consequence of the ongoing access issues, is something that I term in disease inflation. Basically, patients are turning up with more disease, and it's more severe disease, because they've not had access for several years. Dental disease is an ongoing problem. It doesn't stop just because somebody else decides they want it to stop. It's not like an appendectomy. You take the appendix out, you can't get appendicitis again. The only way you can manage that in dentistry is take the teeth out, which is fine, but there's not always the optimum treatment for the patient. So what we've seen now is effectively COVID has crystallised all the underlying issues that have been building up within NHS funding for dentistry. And the outcome is this sort of scenario where we have gross uncontrolled disease throughout the mouth. Interestingly, this picture I took in 1989, when we had a lot of disease still. 40 years ago, near enough. It hasn't changed. I'm seeing this all the time. Routinely, we see this sort of mouth. We're not seeing Hollywood smiles any longer. And the other problem we've got is that the severe disease that's being presented to us leads to severe orofacial infections, leading to admissions of patients. They're ending up in surgery, they're ending up in ITU, and if you end up in ITU, you've got a 5% chance of not leaving ITU. They have prolonged recovery, time off work, and disability as a consequence. These patients are suffering as a failure of the provision of NHS access. When I was a trainee, we didn't see this problem very often. Well, probably I admitted a handful of patients over the year when I was an SHO. My colleagues now in hospital are seeing this every other day. This is just not acceptable. And the reason we're seeing this is because when I was a trainee, we had open access to dentistry. We had an open-ended contract. You could get a dentist wherever you wanted to. Nowadays, you simply can't. And the ones that really concern me are the ones that my young trainee was telling me about the other day. She admitted two children, to a local children's hospital, who then went to theatre for uncontrolled orofacial infection. The vulnerable, the children, those with disabilities, dental disease is associated with poverty and with vulnerability. If you can't protect those as a society, it is a desperate scenario to be in. So that's where we are in the first part of the 21st century. Where are we going in the 21st century? We're at a divide in the road. We have a really important decision to make with dentistry now. Do we retain it within the NHS or do we lose it? I would argue we retain it because as a society it is important for us to protect all of our vulnerable members, and that's what we're not doing at the moment. What can we do to make it change? Prevention is the panacea. Prevention is apple pie and motherhood land, and that's where the government are at the moment. They think fluoride varnish and toothbrushing will help to make everything better. They're completely wrong. We need to get dentists doing lots of dentistry again. We need to access missing funding, that missing 25% of the dental budget that they can't even let to contracts now because dentists won't take it, because it's too poor for their practices. So how do we get it? We need to access that money. You'll have seen the government's talking about tie-ins for new graduates. It won't work. You can't force dentists to work in the NHS. If you do, you just find that they end up resenting you. You want to change their terms and conditions, sort it all out to make it attractive so that people want to work in the NHS. If they want to work in the NHS, they will deliver the care you want. And underpinning all of that, we need to go back and revisit fluoridation of the water supplies nationally, because fluoridation will impact most for those who are most vulnerable and produce, interestingly, you will see changes within 5 years in the child population, in the level of disease they're suffering, if you fluoridate water supplies. So for 21st century outcomes, we need to improve oral health. We should be able to do it. Could we improve quality of life? We certainly should be able to do it. And as a consequence, we should be able to reduce long-term costs. Thank you for listening to me.